We'd like to open it up to either questions to the panel or any feedback. Who'd like to start us off? Malcolm.
Well, thanks to the panel for some fascinating insights. The older I get, the more interested I am in power and money. And so the insights that both Professor Campos and I think Dr. Kaufman provided around community health workers, I think are really important insights. And so my question for Dr. Kaufman is really, could he flesh out a little bit more what he means by the power of the community health workers and how he thinks that mutated in that direction, because I think it's a very important thing. And my second question to Dr. Kaufman around the money issue is the return on investment issue that you talked about with regard to the insurers, tremendously important, because as you well know, there's not a whole lot of the pie increasing in size. You've got to redistribute the pie. So I'm wondering if you could tell us a little bit about the financing and explicitly whether you got money from the health insurers to do some of the work.
Thank you for the question. What I see is academic health centers will do studies that can demonstrate the value, but they're huge operations, hundreds of millions of dollars that are very hard to change. So the question is, what is the force, economic and political force that makes that change? And one is government spending. So the Affordable Care Act has made a bit of a change. But the most amazing one to me is how in capitated arrangements, and this is sweeping the country, whether it's an accountable care organization or bundled payments, all of those say you have a X amount of money to take care of this population. That is what's made the radical change. It's created the first major force against tradition where you have to change, and just like decreasing readmission rates. How are you going to do that without social determinants? What I said about community health workers is not so much as in Brazil, where they are a strong political force per se. It's just that their work is heavily supported by managed care in our state. They're doing more in social determinants than the rest of us are, and they're saving money in this way. Managed care gives us money, and they give us $321 per member per month to take care of the top 5%. We've negotiated that they'll pay us $5.75 to take care of the rest of the 95%. So that's where the money is. We hire them, we put them in our clinics and in our communities, and then they report each patient that they're managing back to managed care monthly. We pay the community health worker $17 per hour. That's a very good pay in our state in a poor community. And so as that increases, it increases the economic base. What the managed care does, they then look at their costs, and they look primarily at ER visits, hospitalizations, and medication costs. And they make a calculation of how much money they gave us to hire and manage this and how much money they saved. And we've done some studies, which is kind of a before and after. We have all the data for the top 5%. Now we're doing a major study prospectively of the rest of the 95%.
Yeah, thank you. This is tremendously important because this is what will drive change, I think. So thank you very much for those details.
Thank you. Brenda. Mm-hmm.
Thank you. Dr. Baxley, thank you very much for your presentation. It's very exciting to see that you started with faculty in your curriculum renewal. One of the questions I had about what you did is it was a perfect opportunity to integrate the IPEC competencies around interprofessional team training. And I'm wondering, was there any purposeful training around team science? You mentioned there was a cohort effect and you had to make some changes, but were they actually trained in some team competencies so that they could be future facilitators of interprofessional teams?
Yes, thank you. Great question. our fifth learning session in that series of 6 in learning the new competencies was 2 days focused all on interprofessionalism, interprofessional practice, interprofessional education, and some on interprofessional research. So there was very deliberate training for that group of faculty in those competencies. Some of the people who joined this, the cohort itself ranged anywhere from a chief resident up to a faculty member who'd had 30 years of experience in medical education. So it was quite a broad group. And so not only for the teachers of these teachers, but some of them themselves had experience. And that's where we really saw the shift from us teaching to them teaching each other as well. So the IPEC competencies were very closely embedded. Of the new educational products, if you will, that we have now, I think from what we heard yesterday, there were 6 or 7 of them that distinctly had IPEC competency training built into the educational contributions they were making. And it was anywhere from, one of that's in particular, we had 2 of the products. We said no lectures. You cannot give us a lecture on something. And they went they had simulations, so interprofessional simulations that highlighted those, all the way to gaming. And one of the nursing faculty working with us, contributing to this combined curriculum, worked around a gaming situation that was a Monopoly kind of game and has already tested it with some of our students, where they're actually pulling cards and they're having to do tasks or answer questions. And one that she talked about that was most memorable was a medical student getting a card that said, describe what a nurse does. And she's like, I don't know exactly. It was a first-year student. I mean, they weren't experienced. And it really brought home that something as simple as gaming, it really got their attention. It was competitive. And she did use IPEC competencies building into that. And so we're going to be incorporating that now very early on. The nice thing about these new competencies is it doesn't matter what health profession student or what year they are, because you don't have to worry about what baseline knowledge they're coming with. And so her idea was, let's don't wait till they get to their clinical years. Let's do this at the first. So I hope that answers your question.
Afaf, you have to find a microphone.
Thank you for giving me a chance to say something and ask a question. So I have 2 quick comments, and then I want to ask a question of the panel. So I came today to see if we are making progress or not, and I'm just so inspired. So thank you, Malcolm and Susan, for really taking this forward. And thank you, the 2 coordinators, for planning this fantastic panel that really shows that we are making progress with tangible examples. And I've learned that now we are more open to learning from our international colleagues and adopting some of the ideas to improving our healthcare system. So to Dr. Baxley, I want to say that it's not only learning, practicing, and teaching, but it's also changing policies. Yes. So that's the piece that I heard you talk about, because those people who are coming out of that collaborative are really changing policies in the healthcare system. Now, my question is related to community health workers, which is something we have learned from our international colleagues. They usually are mostly women. And we have learned that they are a most vulnerable population who takes care of the most vulnerable population. So they are really, it's a blessing, but it is also problematic in terms of those women who become really exploited as community health workers. So my question to the panel is, what are we doing to open the doors for those mostly women who are community health workers, really important, and that's in Brazil too, to continue with their education, to continue improving themselves, to continuing going up the occupational ladder. And I would really appreciate a little bit of thinking about this and maybe comments that something is actually happening to preserve the integrity and the development of this group of women.
I'll speak from New Mexico's perspective. First, when a university becomes involved with community health workers, it's not always so pleasant, and it's not always so accepted by the community health workers, because their view is, we've been doing this for 20, 30 years. Now you're interested in us? And by the way, you're getting some money. How come we're not getting all that money? So there's a power differential. So we have to be very careful as employers. Are we incorporating them appropriately in our teams? The biggest problem is that from an academic center as an employer, they're not like other professionals. Their knowledge is community knowledge, which is not valued as much in academic centers. So that's why we've had to make a change and say they are part of a team. They are part of the huddle in the morning. They have unique knowledge which you don't have, and their information has to go on to the medical record. That's the first. The second is what you alluded to, which I think is absolutely right. We now have a statewide certification program in New Mexico. There's about 7 or 8 states that do this. It's a year-long course. Most of it is practical, and you can take it by distance. But it's a way of kind of standardizing what everyone has as a general skill, and then there can be specialization. But now we're looking at career ladders, and that's very important. At first, I thought, well, maybe they would like to become medical assistants. Then I discovered the medical assistants don't make as much money as they do, and they're not as broadly trained, so we have to be careful. So now they're looking at college degrees, masters, to move into social services and behavioral health in particular.
Thank you. Can we switch back to this side?
Yes, good morning. It's Björk Palstutter from the Training for Health Equity Network. First of all, I'm very proud to say that UNM is a part of our network. But I wanted to ask Dr. Kaufman to speak a little bit more about how the social determinants of health is integrated into the education of medical students, for example, and other health professionals at UNM.
Thank you, Björk. We have curriculum elements on social determinants, but I don't think that's the way people learn or care about social determinants. It has to be practical and it has to be personal experience, and I think that's what you were describing, both my colleagues were describing. Every student, medical student at the University of New Mexico has to graduate with a certificate in public health. Now, we don't want everyone running around getting masters of public health. That's not the point. The point is that they have to understand that the old method of being well-trained to take care of individuals after they're already sick is not going to improve the health of society. So every student has to be able to look at what is the population perspective. And like I do a lot of ward rounds, I always ask, every admitted patient has to have this question: how could this admission have been prevented? Every single one, there was something that happened, and invariably they're social determinants. We had 2 patients one week, I'll just do this quickly, who were both admitted in diabetic ketoacidosis. They didn't know each other. They both had the same problem. They do piecemeal work. If they left their work, they could lose their jobs. And our pharmacy was only open 9 to 5. They couldn't get off to get their insulin. This is unbelievable. So we had to change a policy. But it was the students who had to go to the administration to change the policy. They'll never forget that. That's a living experience. Every student and resident in our system has to do a community project. So that's, to me, that's the way they learn it. Yeah, we say it and they read all about it, but they have to do something about it.
Thank you. Back to this side, Jan.
Thanks for the wonderful presentations. I think a lot of us share the feeling that we try to prepare our students to be good professionals, and then they are confronted with the drivers in the health system that go in the opposite direction. And so we were wondering, with the 4 departments of primary care in Flanders, what can we do? And we decided to go for a political proposal. We wrote together, we changed primary health care now more than ever, and we made a press conference. And this document is now at the table of all the politicians and the ministers. So should we not, as academics, not only prepare our students the best we can, but maybe also work to change our health system so that what we prepare can also be put into practice? And I think there we should liaise with health services research. We now demonstrated in the research projects that integrated needs-based mixed capitation at the primary care level, that it economized 25% in terms of funds for medication, for lab testing, and for medical imaging compared to the fee-for-service system. So I think that for academics, time has now come to take also the political responsibility to engage in a societal debate with the other stakeholders about the political choices that should be taken for the future.
Thank you for that comment. Our panelists, any comments?
We had a mantra that people in our system know, which is, that started with this program, which is the clinical practice is the curriculum. And when we set out to do this, our first partner, even before we approached the AMA with their call, was our health system. We're a community-based medical school. We don't own our health system. It's an open staff model, so we have a mix of faculty physicians, employed physicians, and independent physicians. And we were able to engage them very early on because we said, we're not talking about curriculum. We're talking about, we want to partner with you to change the health, to improve care, to make safer care, and to make higher quality, lower cost care. We're also going to work on the cost consciousness side with you. And that really got their attention. I've been asked as often as any time to come talk to our health system leaders about what's happening with this program. We actually had a private ENT physician in the community who said, can I be in this quality academy? And he came and joined it, and it's not a faculty physician. So this program, which started about curriculum, has strengthened our relationship with our health system dramatically. And the ability to have this, 29 new people now, 28 new people now that they can count on as they're doing their work in the health system and in the community. I mean, it's not just a hospital, it's a system that works in the community as much as anywhere, so that they have these folks that they now can call in because they know they've got these competencies. I think that you're absolutely on track. The practice, what our students live and see is what they leave with, more so than what we teach them. So that's absolutely.
Thank you. Lisa, we'll take one last question before break. Go ahead.
Question for Dr. Hasbury. I'm curious if in combining the PA and the MD classes, if you're noticing now that you've stimulated conversation amongst any of the other healthcare professionals of really looking at doing the same, and if so, in which areas? And by the way, this panel has really been exceptional. It's wonderful to have these pragmatic presentations. Thank you very much.
Well, thank you for the question. And so we do have a fairly long-standing tradition, obviously, at our institution for having the students together for some of these activities. This most recent change that has resulted in us including our students together really for that whole preclinical phase has triggered a variety of conversations on campus. We have, as a result of that, actually worked hard to implement a variety of interprofessional education activities, one of which includes actually having I'm going to miss a profession here, so bear with me, but nursing, pharmacy, social work, the library health sciences students, PA, MD, dentistry, all come together during the very first week of their very first on-campus training to do interprofessional education activities around a case. And so there's a video presentation of the case history, physical exam, etc. They then meet in groups throughout that whole year, interacting with each other. We've even created a version. We use Epic as our electronic health record. We've modified that so that we can deliver case material to them in a safe, non-production format. But they're learning about the health record at the same time they're interacting with each other asynchronously, having a chance to exchange notes and conversation. So it's triggered a lot of very valuable and important, I think, discussion about how can we collectively prepare the best teams to function in as close to or a high fidelity sort of setting where that's very much like what they'll experience in their practices after graduation.
Thank you, panelists, and thank you, audience. We'll reconvene after break at 11:30 and continue the session.